Thank you very much for the introduction, and thank you very much for the invitation to come and speak this evening. My name is Pete Pockney. I'm a senior lecturer in surgery at the University of Newcastle and a consultant surgeon at the John Hunter in Newcastle. I've got no relevant conflicts of interest to declare this evening, but I do have to acknowledge the huge contribution of the team that has been put together in Newcastle to do this work. In particular, I'd like to highlight Dr. Marion Holmes, one of our research fellows this year, who has done an awful lot of the work. So our project was to analyse our performance at emergency laparotomy, to compare where appropriate to the standards which are being established, at least benchmark standards that we could compare ourselves to from the emergency laparotomy process in the UK. And were there any obvious lessons we could learn from this experience? So this is, if you like, the first cycle prior to intervention of an audit cycle in our unit. This, for those of you who don't know it, is Newcastle in New South Wales. It's a significant sized city at the mouth of the Hunter River. This is the John Hunter Hospital, 10-12 miles inland from the coast, right really in the middle of the metropolitan area of Newcastle. This is New South Wales, which is a state on the other side of the country, and Newcastle is smack bang in the middle of it here, about 100 miles, 150 kilometres north of Sydney on the coast. In Newcastle we have our own metropolitan area to look after, but we also have very substantial hinterland going up towards the state line of Queensland, up the mid-north coast and out into the mid-west. In this area there's approximately 1 million people. There's no other significant sized referral hospital. So we provide a local tertiary service and a referral service and retrieval service for a very substantial area. It's 800 kilometres or so to the state line, and we go inland about the same sort of distance. So we've got a big place, at least reasonably big by Australian standards, 600 plus beds, 15 operating theatres in the main building. One of those runs all night, every night, and the other one usually runs most of the night. So it's relatively busy by comparison with a lot of metropolitan hospitals in the other big cities in Australia. Our project was to look at 18 months of our data. We mimicked as best as we could exactly the data set that NELA collects. And we ran we've done this data looking back from the beginning of last year for the whole of 2016 and the first 6 months of 2017. We recorded the same parameters, we scored P-POSSUM, and we recorded this all in a secure online database hosted by the Hunter Medical Research Institute. We also calculated where we could the NESQIP calculation to compare that with the P-POSSUM and see whether that gave us a more useful or more indicative outcome for morbidity and mortality in our patient group. So our results thus far, we've looked at about 220 cases, just over 220 cases in that 18-month period. What was interesting to us was that when we trawled our various various information systems for the laparotomies, when we pulled out the case series and analysed them, somewhere between a quarter and a third of the acute laparotomies that most of us would recognise as acute laparotomies for one reason or another are actually excluded when you look at the inclusion criteria in NELA. We've excluded those from the database here, so what we've got here is our, as best as we can, direct comparison with the NELA data set. I say we've got weak comparative statistics. That's because we haven't done comparative statistics at any great depth yet. I think that the data that we do have is a reasonable place to start from. And the most important thing that we've learned thus far is about the process, and that's what I'll be emphasising. What we've learned from the process is that our documented use of risk prediction tools in our service is dire. That's the only word that we can use for it. It's dire. It was 8 out of 221 cases, of which 7 of 8 were a finger in the air, otherwise known as clinical judgment. Only one person in this 221 emergency laparotomies had a recognised risk prediction score recorded in the notes. Our use of ICU, pre-op and post-op, is similar to experience here in Perth, as we've been described in more detail by Dr. Aiken. Our use of that was similarly not very good. 80% plus of the cases didn't appear to have been discussed with ICU pre-operatively. About a third did go to ICU post-operatively, so and the implication of that is it was somewhat of a surprise to them to be phoned from theatre to say, we've got somebody for you. 5% of our patients went back to HDU or ICU having been initially sent to the ward. So for this patient group that we didn't talk to them about more than 4 out of 5, 2 out of 5 ended up going to the unit at some stage in their care. Our involvement of consultant-level staff in theatre was actually pretty good. Surgeons and anaesthetists both. Almost all of the patients were operated on by either the consultant or a post-set fellow. We have fellows in training from both the Colorectal Surgical Society scheme around Australia and New Zealand, and from the equivalent upper GI and HPB and SCOSA societies. And those fellows often act as a supervised consultant and therefore are eligible and appropriate to be operating on these sorts of patients once one of us has been told that that's what they're doing. The staffing structure is slightly different from anaesthetics. They have slightly more fellows who are post-equivalent qualification in anaesthesia. And again, most of the patients were anaesthetised or supervised in anaesthetic by an appropriately qualified person. Overall, our mortality, subject to the rider that one more or one less death in our series would make a 0.5% difference to the overall morbidity, overall mortality, doesn't look too bad compared to NELA. Our 30-day mortality was 11%, NELA in 2014 was 11.7, and 2015, 11.1. Our 90-day mortality, so again, is very similar, 14.7%, and the NELA combined data for their first 2 cycles was 15.6. So we look like we're performing at about the same level as the average performance in England and Wales. What we've learned is that careful quality improvement takes time, patience, and effort. It does lead to changes and improvements in practice. Amongst ourselves as the working group on this, it's already started to change what we do. And one of the things that it's changed is that we are now asking for every patient who's presented at our mortality meetings has this sort of scoring process done, at least at the point of where we can, looking at what went wrong, whether we should have been operating on them or not. It's chucking up questions about where we can ask questions of our processes of care. In particular, given our referral area and our role in the health economy in the district, we think that transfers from peripheral hospitals are a significant issue. Now, some of these peripheral hospitals are by no means rural or remote. If you stand on the roof of the John Hunter, you can see 3 of them in different directions. And it's an open question when they transfer modestly sick patients to us because they don't have HDU or ICU facilities about whether they should be admitting them in the first place or whether they should be being transferred on recognition of risk rather than on when they actually do need an operation. It's clear that our use of HDU and ICU pre and post-surgery leaves a lot to be desired. Some of that is a resource issue, as has been alluded to, but we need the data to be able to argue for better. We're not very good at writing down who's made the decisions when. I actually don't believe that we're as bad as our data suggests we are at getting consultant involvement in taking a patient to theatre or not, but we don't write it down, and as we all know from the medical legal world, if you haven't written it down, you haven't done it. So our record keeping leaves an awful lot to be desired too. Overall, does NELA work here? Could NELA work for us or a process like that? Unquestionably, with 1 or 2 small qualifications. NELA currently excludes these important categories of operations, and part of our discussions this afternoon was what would we choose to include or want to include in a national or transnational equivalent in Australia and New Zealand. And I think we came to pretty much the conclusions that I guessed at from when I was writing these slides over the last few days, that if we do go ahead with this here, we would want to see these sorts of things included because they are a significant part of the emergency laparotomy workload in most hospitals. Our next steps, we'll be collecting prospective data from now forwards. We'll be bringing other hospitals into our database, other local hospitals, in particular Gosford Hospital, which is on the Central Coast, which is halfway between us and Sydney, which is a metropolitan hospital serving a population of another 350,000 or so. And we'll also be involving our local satellite hospitals in Hunter, New England. We've got the ethics for that. We need site-specific approval. We'll grant access for them to enter data into our database, and we will be amending that database to reflect the progress of the working group that was meeting today. If we do that, the local hospitals will be able to see their performance compared to the average of what's in the database, and they'll be able to see it pretty close to real time. But they won't be able to see details of individual patients in the other hospitals. Thank you for your attention.